reason we're taping it really is so that people who don't have an opportunity to be here can take advantage of that. And by way of that, well, in my introduction, I'll tell you the kind of available informational YouTube videos that Dr. Scholz, through his organization, PCRI, makes available, which is really unbelievable. So, but keep that in mind. Just from a like a format kind of thing, I'm encouraging people to put your questions in during the talk in the chat. We'll try to address those. Alex will be looking at it from her end. We'll be looking at them, and we'll try to make sure that those questions are answered. We'll bring them in. Essentially, Dr. Scholz is just going to be covering most of the latest, greatest things that are happening in prostate cancer. And it's, I don't know exactly, but 25, they will take maybe 20 to 30 minutes, and we'll have a lot of time for question and answer. We'll probably also open it up at that point after we go through the chat room questions so that you can also ask questions of Dr. Scholz and listen to his answers. You know, sometimes that's the best way to learn about prostate cancer. You hear the questions and they highlight different points, different concerns. Let's see. So we'll have it muted during the talk portion of the presentation, and then we'll open it up after the question. So Dr. Scholz, really, I'm reading from some of his curriculum vitae here, double certified medical oncologist. He serves as a medical director of prostate cancer oncologist in Marina del Rey. It's essentially one of the premier places to go for prostate cancer treatment and consultation. He also is the executive director of Prostate Cancer Research Institute. If you have prostate cancer, you should look up this website. On the website, beside all the information they provide, there is a slew of short videos discussing different aspects of prostate cancer diagnosis, staging, and treatment. And you can get all kinds of information from that. I think that's one of the great benefits of what PCRI has done. But even the larger, more important thing, I think, is the upcoming conference. So there's an upcoming conference. It's an annual conference. It takes place down at the airport Marriott this year. We're going back to the Marriott. And it's Friday, September 5th, 6th and 6th, Saturday the 6th and the 7th. Not only do you get top people from around the country that come to this, but they're so accessible. I mean, they're giving large group talks, but then they go to breakout rooms, have conversations with some of the top prostate cancer specialists from around the country. And it's just so nice to be around other people who are participating in their fight with prostate cancer. It's really a wonderful conference. We will be there with the cancer support community, and they have support group meetings as well. And Alex tells me she is going to offer you guys are offering a discount, so that literally it's $15 with the discount. She'll tell you maybe more about it at some point. So I mean, it's nothing. The parking is really, parking costs more than, and the main day is really Saturday morning, but it's really a terrific conference. So that Dr. Scholz has been keeping alive for many, many years, and that conference takes place. If you are fortunate enough to get to that before you start doing stuff, you are really going to be in a great position. So then Dr. Scholz got his medical degree at Creighton University, was at University of Southern California Medical Center. He's written many books. The latest book, The Key to Prostate Cancer, and my personal favorite, The Invasion of Prostate Snatchers, which is a very accessible, easy to read book, but really sort of gives you a broad overview of dealing with prostate cancer. So with that said, I'm going to turn the Zoom over to Dr. Scholz. Remember, if you have questions, just type them in the chat. We'll get to them and at the floor. I don't know if you wanted to add anything, Alex, or yeah, okay. Oh no, you're muted.
Oh no. No.
Oh, I thought you were just being so polite while I was rambling on and on.
Can we have it on this?
It is. Oh, you want to change the screen setup? Yeah, to.
We have a deep
It was under Richard Land.
Oh, that's why I didn't put it.
get it in a second. There we are. I think now you can speak. Let's see. Say
Hey,
something.
it works. Can you guys hear me?
Yes,
Awesome.
perfect.
Yeah, I muted it because we were checking on something technically, so you can blame me for that. Yeah. Yeah, but thank you so much, Dr. Axelrod. You have been this incredible pioneer going and just leading these support groups for so long. And I've had the honor of coming to your guys' support group before in person. I had a dear friend named Bob Each, and he would always bring me with him sometimes. And he was one of my favorite people probably on the planet. And so yeah, it was great to be there with him. But you also, Dr. Axelrod, I just have to applaud you because if it wasn't for you, like this group, I don't know, you guys have been going for so long, and Dr. Axelrod has just been such a pivotal part. And he's also going to be a support group leader at our conference in September, which we're very honored to have him. All the patients really appreciate him. So I just want to give some of that love back. But yeah, thank you so much. I don't really have much to add besides, yes, it'll be $15. I figured I could just keep nodding to all of your answers, and you had them all correct, so I didn't have to change much. But we would really love to have you in person. As he said, the speakers are very accessible, and if you come by me and you're like, Alex, I need to talk to this person, we will make that happen. And so it'll be really great. We're going to be covering insurance denials, reimbursement. We're going to be covering advanced care, active surveillance, genetic testing, imaging, the latest assays. It's going to be a really great time. And if you're familiar with our moderator, Dr. Mark Moyad from the University of Michigan, he will make sure it is fun and entertaining for a lot of education that is taking place. So thank you so much. And yeah, the code is SG, which just stands for support group. And so it'll be $15, but we would absolutely love to have you there. And without further ado, I will have our wonderful Dr. Scholz come and speak to you.
Oh, thank you for such delightful introductions, and thanks for inviting me to share my thoughts on the just some ideas about. Everyone's always asking me, the one question I get is, what's new in prostate cancer? So I thought we could take maybe 20 minutes to cover those initial thoughts, and then we can just do some questions and answers after that. So hope you're all having a decent evening, and I hope I can make it a little more interesting and intriguing. So as I was thinking about this morning, I thought we'd cover three areas of what I feel areas of prostate cancer that are really changing in a material way. And I never would have been able to give a talk like this. I'm going to set my timer here. I'm a very time-sensitive guy. So a talk like this 15, 20 years ago, because the management of prostate cancer was evolving so slowly that new stuff came along every 5 years. Now we're getting new stuff. I had lunch today with some people from Johnson & Johnson, and they have, in phase 1 trials, they have a treatment. This is not one of the three new things. This is actually just something came across my desk today. And it's they were doing what's called a phase 1 trial, which is where someone has a good idea and they find a bunch of really, really sick prostate cancer patients to volunteer to take the medicine to see if humans can tolerate it without excess toxicity. And so in this phase 1 trial, 80% of the patients had declines of PSA. Now, phase 1 means that they probably started off at a dosage too low, and then they escalate the dose to find out what people can handle. And they're not even looking for responses. They're just looking to make sure the medicine is tolerable. But 80% of the patients had at least some degree of PSA decline. And these are men that had already had chemo, immune therapy. They'd already had, all types of radiation, hormone therapies, and nothing was working. So there's some pretty amazing stuff in the wings. And it was fun to see that. Those sorts of meetings never happened, 5-10 years ago. But the three things that I wanted to talk about tonight are impacting people who are thinking about watching their cancer rather than treating it. We call it active surveillance. The second category I want to cover is if you have to have treatment and you can't do anything fancy, you have to treat the whole prostate. I want to talk a little bit about seed implants. That's not a new thing, but I think my perspective on it is a fresh and important perspective. And then the third one I want to talk about is using spot radiation or beam radiation, which is most people are familiar with for curing prostate cancer inside the prostate, but to rely a lot more heavily on that type of technology to help people that have metastatic disease. So I'll just jump right in, and we can't go into too much detail with the limited time that we've allotted for this, but at least it'll give you a little familiarity with how much the field of prostate cancer is evolving and how quickly it's changing. So in the field of active surveillance, we have an uphill battle sometimes because the doctors that are doing active surveillance are paid to do surgery and radiation. So there's a kind of a conflict of interest there in the sense that if in doubt, treat is their motto. And so active surveillance doesn't get the attention that it needs. But that's not the subject of what I wanted to talk about tonight. What I wanted to talk about is the impact of these new PSMA PET scans on decision making. Is there anyone in the room that hasn't heard about or doesn't know what a PSMA PET scan is? Raise your hand. Good, as I would expect. This is obviously a huge technological breakthrough. These scans have been covered by Medicare since 2022. They've been covered by private insurances since 2023. So they've been around long enough for us all to be familiar with them. And these scans are designed to help people figure out if the cancer that they've been diagnosed with is contained in the prostate or not. And if it's not, then you have to adopt more aggressive measures for what clearly is a more serious cancer. So, but how does that affect men with active surveillance? Well, there's an issue with trying to decide when is it safe to do active surveillance as the Gleason score is rising. So we know it's very safe to do active surveillance if the Gleason score is 6. We suspect that it's pretty safe to do it if the Gleason score is 3 + 4 = 7. And as the Gleason score goes higher and higher, 4 + 3, 4 + 4, then very few, if any, people are recommending active surveillance unless someone's maybe in their 80s. So, but what is the Gleason score trying to predict for us? It's trying to predict the likelihood of future metastasis. But I argue that with these new PSMA PET scans, we're getting an even better measure of the likelihood of future metastasis because the men that are walking in the door with, let's say, a PSA of 5 or 6, and let's say they have a Gleason 4 + 4, they've had that cancer already for a number of years. It doesn't become detectable until the tumor gets to a certain size. And it takes, we know, a number of years from the inception of the cancer, the time that you diagnose it, probably at an average of 5 or more years. So when you do a PET scan in someone that has a higher Gleason score, they've had that cancer for 5 or more years, and a PET scan that shows no metastasis. It's not only giving you information about the presence or absence of metastasis right now in the present tense, which is a very important and valuable thing, and that's typically what the scan is used for. What it also tells you is the propensity for metastasis in that specific individual. Remember, Gleason scores are only a profiling technique. What they're doing is they're comparing someone with Gleason 3 + 4 or Gleason 4 + 3 with all the other men that had Gleason 4 + 3, and they're trying to use that information to statistically project the possibility of future metastasis. But we know all 4 + 3s are not the same. Some have a greater or lesser propensity for metastasis. So if you can actually measure the presence or absence of metastasis with a very accurate PSMA PET scan, then you are learning about the propensity for metastasis, not of some just generic 3 + 4 or 4 + 3. You're learning about the propensity for metastasis in that individual. So another way to say it is if that individual has had cancer for 5 years and his PET scans shows no metastasis, certainly he's not manifesting a high propensity for metastasis. You've tested the premise in that individual. It's not a profiling technique like Gleason score. It's an actual measure of the presence or absence. Now, the counter argument, of course, is that the PET scans aren't 100% accurate, But if you look at their accuracy in Gleason 7, it's at least 90%. So it's a darn good insight into the presence or absence or the propensity for metastasis in that individual. And if you take it a step further with that new information, wouldn't this embolden us to consider active surveillance in men who have somewhat higher Gleason scores, but are not showing any evidence of metastasis after a certain interval? Now, this is not becoming mainstream in any way, but imagine if we said, well, to do active surveillance with a Gleason 8, one should probably be at least 80. What about doing active surveillance in someone who's 75 with a negative PET scan? So this is how it usually starts off. We start with lower goals as we test these new premises that maybe PSMA PET scans allow us to be bolder and in foregoing aggressive treatment of the prostate if there's no evidence of metastasis. So that was the first initial thought. We can circle back and do questions about this more when we're done, because I'd like to move right on now, since I only have so much time, with talking about radioactive seed implants. Radioactive seed implants were at one time the most popular form of treatment in the United States. We're talking about maybe 20 years ago. And since then, they've just sort of gone by the by, and unless you ask about them specifically, most of the doctors these days won't even mention them as a possible treatment option. But the reality is that the evidence is extremely strong that radioactive seed implants are, if you're going to try and cure the prostate with either radical prostatectomy or some form of radiation, these are the most popular ways to try and cure prostate cancer, that seed implants are indisputably superior for a number of reasons. The first reason is the cure rates are higher. And that's quite a claim. So how could it be better than cutting out the whole prostate? How could you do better than that? Or why would it be better than, zapping it with proton therapy or photon therapy, IMRT, SBRT? Well, a couple reasons. One is that the dose of radiation that can be safely administered with a seed implant, where all the radiation stays in the prostate, there's nothing hitting the normal tissues, is higher than what can be achieved with any kind of beam radiation. So the killing effect of radiation is directly impacted by the dose of radiation. Seed implants indisputably give a 20% higher dose. And so that results in higher cure rates. And there are randomized prospective trials that prove that. It's not speculation. So why would it be better than surgery? Well, as you know, a lot of the prostate's a small gland, and the tumors oftentimes are near the edge. And if they creep out the edge of the gland, the surgeon is forced to cut through tumor to remove the prostate, because the bladder and the rectum are within millimeters of the surface. So he can't cut a margin around the tumor. And for that reason, prostate cancer treated with surgery often will have a lower cure rate than a seed implant. The seed implant doctors can put the seeds right on the edge of the gland, and it emits about a 5 to 8 millimeter margin of radiation around the outside, ensuring better coverage and better cure rates. So cure rates with seed implants are better than standard beam radiation because the whole dose of the prostate radiation is higher, and cure rates with seed implants over surgery is because you get better coverage around the immediate edge of the gland than you can achieve with surgery. So, wow, that sounds great, Dr. Scholz. It's a one-day treatment. There's no evidence that the side effects are any worse. In fact, the evidence is that side effects are less, certainly less than surgery, and probably comparable in terms of side effects of beam radiation. What's the problem? Why was it the most popular treatment in 2003, 2004, 2005, and now we don't even hear about it? Well, the doctors that give seed implants, the same doctors that do seed implants, also do beam radiation. And when computerized beam radiation came along and improved the technology, for some reason, Medicare assigned a payment structure so that the people that do beam radiation get paid 5 to 10 times more than what the doctor who does a seed implant gets. And so the radiation doctors that are in training are just totally uninterested in learning how to do seed implants, and they're all interested in learning how to do beam radiation. So it was basically just the finances. As for why surgery came back. It was the Da Vinci robot. Prior to Da Vinci robots, that the scar that people had after a radical prostatectomy extended from your pubic bone all the way up to the lower part of your breastbone, and the recovery time was pretty dreadful. So, unfortunately, robotic surgery doesn't improve cure rates. It doesn't improve impotence rates. It doesn't improve incontinence rates over historical, but it does accelerate recovery because the scars are quite small after robotic surgery. So it was an opportunity to revitalize surgery in a world of surgeons. That was enough to set the seed implants at the side of the road. So that's where we are today. Seed implant technology is as good or better than it's ever been. And if someone has bilateral disease and needs to be cured, there are only a few exceptions to why you wouldn't do a seed implant. One would be if the prostate is just huge. That makes it more difficult to do a seed implant. Many of those patients are eligible for what we call focal treatments. I'll just mention that in the passing in a minute. But or if someone has just terrible urinary side effects, we know that the radiation of any type, including seed implants, can exacerbate or irritate the urethra and make that worse. So that has to be solved before you can go rushing into a seed implant. Now, just a very quick word apart from seed implant theme of this second point, I think is so important for people to understand, is the idea that when people have really big prostates, the total amount of radiation that's going to be administered with an intense seed implant is going to start to become a problem. So you can shrink it with hormone therapy, but I think an even more plausible thing, if people have a single cancer, and this is usually the case if you're catching this at a fairly early stage, men with big prostates set up very nicely for something called focal treatment, where the radioactive seeds can just be put in the region of the tumor, not the whole prostate. And that is going to reduce side effects. And of course, it is going to be entirely effective in eradicating the tumor. The only downside is you do have to monitor the rest of the prostate for new cancers someday, because prostate cancer is a common problem. So anyway, that's the brachytherapy aspects. We've covered the brachytherapy, we covered active surveillance, and moving on to the third topic I wanted to talk about was how PSMA PET scans have changed the management and the treatment of early metastatic cancers. So metastatic, not all prostate cancers metastasize. In fact, only a minority metastasize. Those are the ones you hear about, the ones that spread. But most men don't even know they have prostate cancer. They say you can put a percentage sign after a man's age, and that's how likely he has at least some sort of prostate cancer. But when people get diagnosed and treated, or if they aren't checking their PSAs and the cancer jumps around their body and they have metastatic disease, maybe their PSA is 100 or something like that. The usual approach, of course, is to give men hormone therapy and try and get the PSA down to 0. That's been the historical management. But when you look at people with metastatic disease that are properly treated, you're usually talking about a minority of people these days who have had surgery or radiation in the past. 2 or 3, 4 years later, the PSA starts going up. People get a PET scan, and lo and behold, there's a metastatic lymph node somewhere. Maybe the PSA is up to 2 or 3, and they can see a spot with the PSMA PET scan. So historically, the management of those individuals consisted of hormone therapy for 18 months and ideally radiation to all sites of diseases. Some centers just put people on hormone therapy and they throw in the towel, say, oh, it's metastatic, we can't do anything. And we'll just leave them on lifelong hormone therapy. Or if they're a little more enlightened, they'll put them on intermittent hormone therapy. But more and more of the doctors are realizing now that these men with early metastatic disease can be cured with radiation therapy, with or without hormone therapy. So the really cool thing is that in men that have had previous treatment and let's say their PSA starts going up, there is an option for simply radiating the metastatic site and foregoing hormone treatment altogether. And this is really popular in men that have, types of cancer that, they had a Gleason 8 and they had 2 years of hormone therapy and they had radiation to their prostate. And 3 years later, the PSA is going up. a PET scan shows that there's a metastatic site, and they're going to put them back on hormone therapy for a couple more years or for life. Those individuals quite possibly can be cured just with radiation and without any hormone therapy. And one of the really cool things about this approach is that when you do radiate a metastatic site that's diagnosed in an individual like I'm describing, then you're going to get very quick feedback as to whether it's successful. The PSA should go back to 0 after the radiation. If you put someone on hormone therapy, their PSA will go down temporarily, but it doesn't prove that they're cured. Whereas if people have a metastatic site and you only give them radiation, the PSA will, and the PSA declines down to 0, then that's a very strong argument that that was the only cancer and that your radiation therapy quite possibly has actually cured the disease. So that, I think, the fact that some men with metastatic disease are getting cured with just radiation is thrilling on a number of levels. First, talking about curing metastatic disease is amazing. The second amazing thing is men that have been through previous hormone therapy are extremely excited about the possibility of undergoing treatment that doesn't require further hormone treatment. So this is, I think, an amazing big breakthrough in that we're discovering just as in the process of ongoing management of patients, that certain individuals with metastatic disease can be treated without hormone therapy with effective radiation, and some of them are getting cured with this sort of salvage approach. Very exciting, big breakthrough. And I think with that, we'll move on to your questions and answers.
So why don't we start, Dr. Scholz, with the chat room questions. We'll start, I don't know, if you have them, you want to, Jeff has got them on his screen, or you have them, and we kind of go through and then we'll open it up to the rest of the meeting as well. But,
Dr. Scholz, do you want to read it from your screen or do you want me to read it too?
I'm sorry, what was this saying?
Can you ask
you
me?
want to read it?
You go ahead and read it, whatever.
Okay. Where does Keytruda fit into the prostate cancer treatment? At what point in the disease? What does it do?
Sure. So Keytruda is an immune therapy that is FDA approved to treat lung cancers and melanomas, and it's an effective therapy. We do use it to treat prostate cancer. The manufacturer, Merck Pharmaceuticals, has been very kind in providing free Keytruda on a compassionate use basis because Keytruda is not FDA approved for prostate. So there's two situations where we consider using Keytruda. One is a genetic profile called MSI high, and this is not just prostate cancer, but any tumor that has a certain genetic profile called MSI high. And this is determined by getting genetic testing with something like Garden 360 or Caris or Foundation One. And they just test your blood and see if your tumor cells have a certain type of mutation. And when people have MSI high, it's like winning the lottery. So almost all these patients have fabulous responses to this immune stimulating medicine called Keytruda. Problem with MSI high is it's rare. I mean, I've only seen 2 or 3 cases, and I see hundreds and hundreds of men with prostate cancer. So it is a fantastic and exciting time. So that is the most compelling place to use Keytruda. In terms of other situations where we use Keytruda, we realize that it's not a, it's not a gangbuster in general for men with prostate cancer. And this is for people that have advanced metastatic disease. It's not, Keytruda can overstimulate your immune system and cause side effects that are problematic. So it's only to be used in someone that you say, okay, the cancer is pretty serious. Can we get some mileage out of this medication? Of course, prostate cancer is a nice cancer to experiment with something because you have PSA levels to determine if you're getting a good response. So, for example, let's say someone has been on, has metastatic disease. They've had a decent response to hormone therapy, and they stopped the hormone therapy in the past, and the PSA went up pretty quickly, and they had to go back on hormone therapy to get the disease under control. But they're really tired of the hormone therapy, and they'd like to stop the hormone therapy again and see if they can get a little longer remission, get their testosterone back. That would be a natural place to see if Keytruda in that individual, when he stops testosterone blockade, would be able to keep the PSA down, keep the disease in check. And we've gotten lucky with some patients where they would maybe only be off treatment for 6 to 9 months because their testosterone came back, their PSA came up quickly. And then on a subsequent cycle where we took a holiday from the hormone blockade, the Keytruda caused the PSA to remain stable for very extended periods of time, sometimes for years. So there is a slot for Keytruda in certain situations. It's not something to be used in someone with a PSA of 300 and their cancer is rampaging along. But someone who has had a good response to hormone therapy and is but are getting short holidays when they take time off hormone therapy, they might be able to keep their PSA down with an immune medicine like Keytruda. There's another doublet called Opdivo and Yervoy, from Bristol Myers, similar but not identical immune therapy that can be used in the same way as Keytruda.
Okay, next question. A man has MCPC and is not PSMA avid. What other cell surface targets are being used in current clinical trials? What is the best way to find those trials?
Okay, the first alphabet soup letter, the MC, they have what? MCK what?
MCRPC and is not PSMA avid.
N as in Nancy, C, is that what you're saying?
Mary, Charles, Robert, Paul, Charles.
Metastatic, yeah, I don't know. That's some sort of castrate resistant or castrate sensitive.
Okay, let me unmute Phil.
Let's Phil,
Meanwhile, let's go to the next question, then I'll unmute Phil.
Okay.
How effective do you think the 4K score PSA test is? My husband's score said high risk for aggressive prostate cancer. We'll get MRI soon and assume biopsy.
Right. I think it's a reasonably useful test, the OPCO 4K, but all it does is give you a percentage likelihood, which if you're consulting a prostate cancer expert, our clientele is not going to be satisfied with, we think you probably don't have prostate cancer, or you probably do have. So I don't personally waste a lot of time with OPCO 4K. I just order an MRI. But for family care, family practitioners, primary care doctors that are seeing hundreds and hundreds of people, and they don't want to get an MRI on every single individual that gets some elevation in PSA. Yeah, I guess it's okay. But by the time they're knocking on our door, people are very serious about getting a final answer. So that's why we usually just jump to a MRI right away.
Okay.
is Phil free?
Phil went away.
Oh, Phil asked a question and then left. You have other questions?
No,
I'm here.
Phil can
Oh,
say,
Phil's there.
Phil can speak
All
now.
right. But ask your question, Phil. 'Cause
Okay.
I don't think.
They didn't get translated well. Metastatic castrate-resistant prostate cancer.
Okay.
Not PSMA avid. So there may be other targets on the cell surface that could be good targets for treatment, a pretty advanced cancer in the lungs.
Well, in terms of targets, I mean, you're talking about experimental right now. Commercially available things that target surface are not non-PSMA, don't exist. But there are commercially available scans to try and detect let's back up a second. What we're talking about, I've been singing the praises of PSMA PET scans for most of my talk tonight. And what you're describing is a phenomenon where the PET scan is performed in someone with known cancer, and it doesn't show any cancer anywhere. Big disappointment. These variants of prostate cancer exist that don't have the PSMA surface marker, and you can give PSMA injections to the cows come home, and you're not going to see any cancer. So it's essentially worthless in the men that have these variants that don't have PSMA on the surface of their cancer cells. So what do you do with those people? Basically, there's 3 or 4 other variants of PET scanning to at least help you find where the cancer is. What do you do with it is a different question. But finding it with this sort of technology would include Axemin PET scans. It would include FDG PET scans. Axemin is FDA approved for prostate cancer. FDG PET scans are approved for like lung cancers, pancreas cancers, colon cancers, and then C11 choline PET scans, which are only available in one place in the world that I'm aware of, and that is at the Mayo Clinic. So those are some of the scans that can help men at least find where the cancer is, which is an incredibly useful thing in the battle against cancer. There's also an older, you don't even hear about it anymore, way to find small lymph nodes. It's only available in Europe. It's called Combidex. So that is available in Nijmegen in the Netherlands. But so these are some of the techniques that can be used, all of which are superior to the historical scanning technology, which is to use a bone scan and a CAT scan. It shocks me that to this day, I see patients who are being evaluated with bone scans and CAT scans. And I feel like it's going back, someone's driving a Model T. I can't imagine why anyone would waste their time or even bother with such things when the PET scans that are available now are 10 times more accurate. And my gosh, if you're concerned that someone has metastatic cancer, how could you ever compromise and feel satisfaction with doing a bone scan and a CAT scan? It's laughably, ridiculously stupid. But I've seen it happen from university centers because they have clinical trials that are written in the language of bone scans and CAT scans. So they're still doing these antiquated scanning methodologies. Shouldn't be done. And when the PSMA PET scan's not working, which is probably in metastatic patients, maybe 1 out of 10 patients has PSMA negative cancer. Those individuals can be scanned with these other techniques. Axemin PET scans, AXUMIN, FDG PET scans, and C11 choline PET scans.
Okay, this question is, with changes at Johns Hopkins, who do you recommend to send second biopsy opinions to?
Right, good question, because the number one prostate pathologist in the world, Jonathan Epstein, lost his role at Johns Hopkins. He put Johns Hopkins pathology department on the map, and I think few people would dispute that he's the best prostate pathologist in the world. So when he left, our opinion is that they built a lot of momentum there training, because they're doing, 50 to 100 or more pathology reviews a day. So he trained a very competent team, and we have continued to use their services, and we feel comfortable with the quality of reads that we're getting out of Johns Hopkins. So I'm not trying to imply that they're the only place, but they do seem like continue to be a reliable and good source despite the absence of Dr. Epstein.
Thank you. Okay, this is from Lisa. Is surgery possible after you have gone through radiation therapy?
Yeah, a lot of things are possible. I mean, people have climbed Mount Everest. It's possible. Yeah, it's possible. I'm not trying to say that it's as hard as climbing Mount Everest, but the dangers of doing surgery after radiation are quite substantial. And then beyond that, you have the fact that there's other better ways to handle cancer failures in men that have had previous radiation besides doing surgery. So surgery is, in my view, almost always the absolute last choice to do when any kind of treatment is being considered for any kind of prostate cancer.
Thank you. This is from James. Do you combine Keytruda with other treatments?
You can. You're looking at fairly rarefied air when you're giving Keytruda. I mean, I would say in our practice, which, we have the doctors and nurses that are here with me are managing about 2,000 patients with prostate cancer. And I would estimate at any one time that we have maybe 2 to 4 patients that are getting Keytruda. So it's not something that is utilized heavily. Could it be used in combination with something like lutetium? Could it be used in combination with something like Provenge? The answer is yes, but the problem is that because Keytruda is a rather exotic treatment and it doesn't work in everybody, it's nice to treat patients such as this one at a time and see if the Keytruda is earning its keep. Is the PSA declining because of the Keytruda? Now, if you give 2 or 3 different treatments at the same time, you don't really know if it's the Keytruda or the other treatment you're giving at the same time. So it's kind of problematic to give it in combination for that reason. It is feasible, and combination treatments can be more effective, but because of the ambiguity about, Keytruda is probably only going to make a big difference in maybe 1 out of 4, 1 out of 5 patients. You really want to know that you found that 1 out of 4, 1 out of 5 patients if you're going to keep giving them this medicine, which could have notable side effects.
All right, let's see. This is from Terrell. Would you recommend spot radiation rather than resuming hormone therapy after a 3.5-year holiday? Is this holiday length unusual?
Well, I think we should have asked me that question before I gave my talk. It would have been a good setup for it. So the answer is yes. Make sure that the isolated metastasis been diagnosed with a PET scan, not with a CAT scan and a bone scan. We historically did treat metastasis in the era where we didn't have PET scans, and we got some value out of it, but nowhere near the level of excitement that I was sharing with you tonight about people who are diagnosed with METs via PSMA PET scans. And even more encouraging in someone that's had a long holiday like that before the metastasis appeared. So the answer is that sounds like this person has independently arrived at the same conclusion that I have. And we're both in agreement that, yes, it sounds like radiation would be a much more desirable approach than going back on hormone therapy.
Okay, what I'm going to do now is I'm going to ask people to unmute that want to speak. What?
We also want to open it up to everyone here as well.
All right, well, meanwhile, I'm going to,
You can unmute and
I'm going to unmute and then,
everyone be polite because Jeff might mute you all again.
oh, I'm good at that. I will
But
just.
I have a question, Dr. Scholz, while he's doing his unmuting. You mentioned about the active surveillance and the use of the PSMA as a kind of marker for whether you have to treat or not treat. But I was sort of confused because I know, like, if somebody has a Gleason 8, but beside their 8, the factor of like where their PSMA is, did they get diagnosed just a year ago or 5 years ago? In other words, how do you know whether active surveillance is necessary or is possible? Just from, I mean, the fact that they don't have let's say a metastases doesn't, I mean, what if they just got diagnosed, or what if they were, really had cancer 5 years ago?
Sure. So you're articulating the main struggle intellectually that people have with what I'm saying, and I'm glad you brought this question up. I've lost the audience for some reason. I don't know what happened to you all. There we go. All right. So what we're doing is we're arguing on the basis of what doctors call the natural history of disease. Like, for example, the natural history of maybe we could mute while I'm talking, we could mute everybody.
Let's do this. Everyone in the audience, please mute yourself personally, because every time there's a movement, we lose the screen. So if everyone would mute themselves, and then when you want to ask a question, unmute.
There we go.
Mute at your end.
Well, now you put it on.
Well, all right. You all can hear me okay, right? No?
Yes.
There we go. All right, that's better. Okay, so the what's called the natural history of diseases is when people study the pathophysiology of different diseases and cancers, you learn that they have certain predictable behaviors. For example, the average survival after diagnosis with pancreas cancer, not prostate cancer, is about 6 months. So the average survival after someone's diagnosed with lung cancer is probably around 24 months. So those generalities, those averages are certainly a lot different than prostate cancer, where the average survival is the normal life expectancy of a man your age. So that is called the natural history. In other words, there's an innate biologic characteristic of different cancers from different organs. So the natural history of prostate cancer is a lot slower than other cancers. Now, if someone's diagnosed with a PSA of 2,000 and they have cancer in every bone in their body, they're not going to have a life expectancy of someone their age, but those people are not very common. So when you average it all out, the average person diagnosed with prostate cancer has a normal life expectancy. So that natural history, we can exploit that in understanding the impact of PSMA PET scans. So when someone comes in and he has an MRI and it shows that he has a 10 millimeter lesion on the right side of his gland, his PSA is 5, he has a biopsy of Gleason 4+3, and everyone in the world, if the guy's under 75, is going to recommend that he have some sort of treatment to cure it because they're worried that it could metastasize and kill him. But for a tumor to be a 4+3 and be 10 to 12 millimeters in diameter, it takes probably anywhere from 4 to 12 years for it to get to be that size. So think about that. That man has had those cancer cells, that Gleason 7 cancer, already. By the time he comes in the first time, he has a biopsy and they say, you've got Gleason 7 cancer. Oh my God. It's been there for somewhere between 4 to 12 years on average. Okay, so that means that it's had an opportunity to metastasize for 4 to 12 years. And if you have a PET scan that shows in that individual that there's no metastasis, because some men will have metastasis. You get a Gleason 7 and you do a PET scan, there's going to be some men who do have metastasis. And obviously, that's 100% sure that that guy has a type of cancer that can metastasize. There it is. You can see it with your own eyes. But many men who have PET scans with that Gleason 4+3 don't have metastasis. And my argument is that that cancer has had an opportunity for at least 4 years, probably a lot longer, to metastasize, and it hadn't figured out how to do it yet. So if it is going to metastasize, it sounds like it's a relatively stupid one. It's going to take a long time. So much more so than just anybody and everyone that historically we didn't have these types of scans. And so we had to take extra precautions. If, let's say, 1 out of 10 men is going to have metastasis, well, we would treat the other 9 because we didn't have a way to detect these metastases early and we didn't know if they already were present. So we just treated everybody. And another reason that emboldens me to suggest that some of these men might not want to treat and do active surveillance is that if they don't have metastasis now and they're watched carefully, and God forbid, 3 to 5 to 12 years later, they do develop a metastasis, it's going to be detected 10 times earlier stage than it ever would have been detected in the past with CAT scans and bone scans. So those men then could be treated with metastasis-directed therapy with radiation, possibly cured, because you're catching it early with this amazing new technology. And so it's on that basis that most people tend to think of a PET scan as, well, oh, thank God I don't have metastasis today, but tomorrow, you never know. It might jump tomorrow. Let's get it. Let's do operation. Well, thank God it's not spread. So let's act right away. Forgetting that living systems continue to behave in accordance with the way they behaved in the past. It's not like the stock market where they say, you can't judge future outcomes based on past behavior. Biologic systems tend to be consistent with themselves. And if there's a low metastatic potential for the last 4 to 12 years, it's likely to be a low metastatic potential for the next 4 to 12 years. Anyway, what's next? How much time do we have left?
18 minutes.
Okay.
I think the core group is muted as well. Dr. Axelrad's room is muted.
Yeah, it is.
All right, how about that?
All right.
There you go.
Okay. If you wish to be on,
No, this is not good. Do the group thing up in the corner. Over here.
Are you taking a question?
I'm ready.
Okay, if I have a choice between Tulsa and NanoKnife, which one would you pick up? I understand both of them, but don't know much about how much cure you can get from NanoKnife. It looks very interesting.
Well, my question when I get that question is, what do you know about the experience and the results in the doctor who's doing the TULSA and the doctor that's doing the NanoKnife? It's a skill procedure. The tool itself is less important. The doctor who's wielding the tool is 10 times more important than the type of treatment that you get.
That's good.
Oh yeah, it's a very difficult concept that people struggle with because people get dazzled by the technology, which is pretty amazing stuff. I mean, Tulsa Pros, you put someone in an MRI and under direct visualization, they have crossing sound waves that, coagulate the site. It's pretty awesome. And then NanoKnife, they put in 2 electrodes in there and they run high voltage electricity and kill the tissue in between. It's all very intriguing and fascinating, but it's all about where the destructive force is applied, how big a margin has been put around the target lesion, and how skillful is the doctor at actually achieving those goals in a prostate that's wiggling around inside of someone.
Yeah, so the cure rates in the NanoKnife are equally good as Tulsa Pro?
Depends on the skill of the doctor doing the treatment.
Yeah. And there are not too many doctors who do it, right?
I don't care about how many. I just care about finding the very best.
How do we find out if he's the best?
Well, this is always a struggle. When I find someone that knows what they're doing, I always ask my patients, I say, look, I've got this one doctor I depend on heavily, but I'm always looking for volunteers to go out and experiment with other doctors so I can find out how good they are. But no one's taking me up on it. I don't know why.
Okay, we have another question. I had a prostatectomy. PSA never went to 0. Being treated with Casodex on and off. It seems to not show up on the PSMA scans I've had. Would you say an AXUMIN scan would be a good next step?
Right. I mean, we sort of answered that question already, and it'd be a great setup for the previous question we had about PSMA negative disease. The only problem with Axumin PET scans, FDG PET scans, C11 choline PET scans, these are the alternatives to PSMA, is that they require a PSA above 1 before they start to see things. One of the neat things about PSMA PET scans is they can detect cancer at PSA levels under 1, which is fantastic. So if the PSA is over 1 and the PSMA PET scan is not showing anything anywhere, that is more likely to be PSMA negative disease. And using those other technologies that we've already talked about would be a very sensible next step.
And the PSA for the question that was just asked is 18.
18. Yeah. So FDG, C11 choline, Axumin. Axumin would probably be the logical first step because it is FDA approved and most insurances will cover it.
Next question from Lisa. My husband, urologist, said his prostate cancer is only in the prostate a 3+4 Gleason, stage 2 cancer. MRI and biopsy done. How do we know it is isolated to the prostate if no PET scan was done? PSA 7.
Well, we're just back to the era before PET scans. That was prior to 2022. Everyone was profiled on the basis of how often similar Gleason score patients, similar PSA patients, similar MRI patients ended up with metastasis down the line 2, 3, 4, 5 years later after undergoing curative treatment to the spot in the prostate. So this is the problem with the old-fashioned CAT scans and bone scans, is there could be cancer outside the prostate that would be invisible to CAT scans and bone scans. And so we had to guess about or project or profile based on other men with 3+4 with PSAs that are similar, blah, blah, blah. So I can do those numbers in my head. I wrote a whole book about this called The Key to Prostate Cancer, how to profile yourself and estimate the risk of micrometastasis based on all the studies that have been done out there. And at 3+4, you're looking at a fairly low risk, about somewhere maybe in the range of 10%, depending on how much 4. Not all 3+4s are the same. Some have a lot of 3 and little 4. Some people have less 3 and more 4. And there's a difference between the likelihood or the probability that there's something outside that the scan is missing. So it seems kind of crazy in this era to try and go back to doing treatment the way we did prior to PSMA PET scans, considering that this arguably is the biggest breakthrough in prostate cancer in the last 10 years. So to say I want to practice without a PSMA PET scan doesn't make a lot of sense to me.
We have a question from within the room.
Dr. Scholz, are PSMA PET scans available with insurance or Medicare at the diagnosis level? If you've had an MRI and you had a biopsy?
Yes. The magic word you said was biopsy. So Medicare, which, 75, 80% of men who have prostate cancer are in the Medicare age group. And let me just put in a little pitch now. If you have Medicare and you have any kind of illness, don't get Medicare Advantage. Stick with your Medicare so you can make free choices. You'll save a few bucks. And if you stay healthy and you don't need health insurance, Medicare Advantage is an advantage. But once you get sick and you actually need state-of-the-art care, it's a disadvantage. So, all right. So I guess on my soapbox for that. What was the question again?
Is it Medicare and
I remember now. Yeah, is it covered? So if you had a biopsy that confirms the presence of prostate cancer, any kind of prostate cancer, Gleason 3+3, Medicare will cover the PET scan in the newly diagnosed. Private insurances, Blue Cross Blue Shield, United Healthcare, Aetna, these sorts of things, on a hit and miss basis, will cover PET scans in men that have simply been just diagnosed for staging purposes. Some of the private insurances insist that you have a Gleason 7. It's not uniform, but Medicare, no problem. Any diagnosis of any prostate cancer, easy to get a PET scan.
Thank you.
The next question is from Phil. Your opinion of bipolar ADT testosterone therapy?
Don't use it much. It's on the list of things to consider. The times that I have utilized it, the responses that occasionally occur have been brief. So I think there's too many other interesting and effective options that I haven't utilized it much. This is just so everyone knows, this is an unorthodox but intriguing option where men who've become hormone resistant, been through a lot of different treatments, may have some response, that is decline in PSA, by giving them large doses of testosterone. Seems counterintuitive, but this has been reported. It is a real phenomenon. But the response rates, I think it's like, 1 in 6 patients in my experience, and and those responses may last 2 to 4 months. And it's just like, why am I going through this for such a small return on investment? So I don't use it much. There are some reputable people who do. I try and keep my patients out of the situation where they need desperation moves. So it's not a big part of my practice. Even though we have a large number of clients, most prostate cancer is localized or earlier stage, if you look percentage-wise, the men that are out there that have this condition. So it's not like we have 2,000 patients with metastatic disease. So there are probably, there's a guy at the Mayo Clinic named Eugene Kwan who specializes exclusively in desperation situations. And you might want to pose that question to him sometime if you could get him as a speaker.
Wasn't he coming to the conference?
I don't believe he'll be there this year. No.
He's not coming this time. All right.
If you have a muted microphone and can't unmute, send me a note in the chat and I will unmute you if you have any questions.
Are there any questions in the room? Anybody? Are we all good here? Ellen asked this question. Any out in the audience? Raise your hand or tell Jeff and we'll just chat
me a note.
Chat him a note so we'll know.
No, I think all the questions have been asked.
There's two hands up.
Oh, wait.
Yeah, there's a couple hands. There's a
Wait,
couple.
Jim.
There's Jim Chaconis.
Jim, can you guys unmute or you need to be unmuted?
You need to be unmuted, Jim. Nod your head if you need to. He can't talk, so you gotta unmute him.
I'm working on it.
And then also Robert.
Jim Harrison? We're talking
No,
about
Robert. Just Jim Chaconis.
Jim. Hey, Jim's not here. Oh, wait. Maybe it's here. Jay's iPhone. It's Jay's iPhone. Jerry's iPhone? Jay.
No, Jay's phone right there.
Jay's phone. Okay, there you go. You have the floor.
Got it. Dr. Scholz, when a man enters the active surveillance path, he'll be getting PSA testing periodically. How does PSMA PET scans factor in? Are they triggered would they be triggered just by rise in PSA, or would you recommend that they, get a MRI or a PSMA PET scan periodically? And are there any other monitoring techniques once you're in that active surveillance realm?
Sure. I can only say what my methodology is. There's, many centers want to do a random biopsy on you periodically, which we don't do anymore. But so our active surveillance protocol would be to check a PSA test every 6 months and to check an MRI once a year and to do nothing further if the PSA is stable and the MRI is stable. MRIs are very, very powerful for monitoring because it's not an issue of trying to determine if there's something there or not. It's an issue of what is known to be there and is visible on the MRI and whether or not it has changed to any degree in the previous year. So if you're doing an MRI every year, you have a baseline MRI from 12 months ago, and then you get a brand new MRI, hopefully read at a state-of-the-art center like UCLA, UCSF, or UC San Diego. And they compare the image from now to the one 12 months ago, scrutinizing level by level the tumor to make sure that there's no change. And the usual thing is there's no change. That's why active surveillance is popular. These things just sit there interminably and do nothing. But if there is a change, then we recommend a targeted biopsy of the area of change to make sure there hasn't been a new area of higher grade cancer that does need to be addressed in an early and timely fashion. What we're finding with this approach is the people who are selected for active surveillance have these low-grade lesions which rarely change. And probably just as often as not, if they go off active surveillance, it's not because the known tumor changed. It's because prostate cancer is the most common cancer in men. They get a new spot somewhere else. And in some cases, that new spot will have a higher grade lesion than the original one and require treatment. So that's the way we do active surveillance. And you say, well, what's the role then of a PSMA PET scan? And for us, the role is for men that have, it probably used most frequently in men that are have rising PSA levels, and we can't really come up with an explanation. What is a rising PSA? Well, you're probably all familiar with PSA density. You're supposed to take the PSA and it's 10% of the size of the gland. If it's a 50 cc gland, that would be a PSA of 5, and then take 50% of that, 2.5, add it. So for a 50 cc prostate, abnormal PSA is above 7.5. Well, it turns out that a lot of men have abnormal PSA, and it could be because of, is there a cancer we're missing? That's obviously everyone's concern. Is it because there's something outside the prostate that isn't even detected by the MRI? MRI is great for the prostate, but it's not great for metastasis. Almost always, it turns out that men have a problem with nonspecific inflammation in their prostate gland called prostatitis. And these PSAs are chugging along at higher levels than they should, making everyone nervous because the whole idea of active surveillance is to catch every single case before it spreads. You don't want to have something spreading, or if you do have something spreading, you certainly want to catch it at the earliest possible time. So I'd say the most common reason that we do PET scans is because someone's PSA is running higher than it should. And we want to double check and make sure we're not missing a metastasis somewhere. That is the number one reason. The other reason that we'll do PET scans is I mentioned that the people who are being followed more commonly actually develop a new spot that raises questions. And I think PSMA PET scans are good enough that if someone says, oh my God, I had a spot on the left, it's stable, but now I've got a new spot on the right. I don't want to have a bunch of needles rammed in my rectum again. Can't we just do a PET scan? And if it doesn't light up, assume that it's probably not prostate cancer? So PSMA PET scans in those individuals are covered because of the previous diagnosis of prostate cancer, and it may allow some men to sidestep a biopsy, which is somewhat unpleasant, and confirm that a new shadow that was detected on MRI. MRI is not perfect for saying if it is or isn't cancer, whereas PET scans are at least 90% accurate. So that's another role for PSMA PET scans in men on active surveillance.
Yeah, thank you.
Yeah. Go ahead.
All right.
Okay, we have a couple questions that are on the chat, and then we'll get to Jim. We'll get you. Are you going to ask a question?
No, he's done.
You're done.
Yeah.
Okay, put yourself on mute, please.
Yeah.
Okay, 9 years ago, this is from Lewis. It's a two-part question. 9 years ago, I had a prostatectomy with a large tumor half the size of my prostate. It turned out to be slightly extracapsular. Nobody even suggested high doses of seeds to get anything around the edges. Challenging to know what we don't know, especially with how fast medicine is evolving. And I have a second part for that. A second. So that was the first part of the question.
Well, I'm sorry, I didn't get a question. I got a statement. What was the question?
Yeah, Lewis, rewrite your question. Lewis's part two question is, can a Gleason level of cancer change over time, for example, after surgery, ADT, or radiation? That's the question.
Can the Gleason change?
Well, no, I mean, when people do a random biopsy, they're taking 1 millimeter cross sections of a tumor that's 1,000 times bigger than what you're looking at under the microscope. So no, I mean, typically Gleason scores don't change. You can get new tumors that have different Gleason scores. But the usual reason that Gleason scores change, and this has been well reported, like if you have a biopsy and they say the Gleason score is 3+4, and then they do surgery and they found, oh, we were wrong, it's really 3+3. That is a sampling error, which is just part of the game of prostate cancer. We're all aware of this limitation that Gleason scores can change because you might be sampling a different part of the cancer.
Okay, is there any questions from the gallery?
Well, let me go back to the first question. It's the technique of stalling because of the evolution of the medicine. Yeah, does it make sense to pace therapy, because I can't undo a prostatectomy? So what's the risk? It's very interesting you say that the PSMA PET scan gives an indication of that individual's proclivity for the disease to metastasize. And that's kind of fascinating. How do you know by looking at the PSMA if you as an individual are likely to have it spread?
Well, this is the third time we've covered this, and it's appropriate that we've covered it 3 times because it is somewhat of an abstract thought, but I think it has substance to it. And the answer is based on the fact that that individual's cancer has been there possibly for 5 or 10 years and hasn't spread, according to what the PSMA PET scan tells us as of today. So if I'm diagnosed with prostate cancer today, my prostate cancer has already been there for 5 to 10 years. And if the PET scan does not show any spread, how can one not say that Dr. Scholz has a prostate cancer with low risk of spread?
I hear that, but why, after you've had your prostate out and you have extra they found a tumor and we zapped it with high dose brachy, and then maybe somewhere else there was a little spot and now it's raising the PSA slightly. In other words, why does the cancer want to spread? Why is it very happy in a person's groin and just wants to stay there even if you don't have a prostate?
You lost me.
What I'm saying is, why is it just staying there for people who don't have a prostate? Why is it staying in the prostate bed area?
Oh, well, that's easy. It's because I've mentioned this before, that the surgeons have great difficulty cutting a prostate out because it's only millimeters away from the bladder and the rectum. So that they don't cut a hole in your bladder or cut a hole in your rectum, which could kill you. They'll cut through the cancer and just leave it there.
And so it just tends to stay there. Okay.
That's where it grew up. That's its neighborhood. That's where it's comfortable. That's where it's familiar.
All right. I mean, thank you.
We have a question from Lisa. Why do you consider surgery the last resort?
Because I value the ability to stop urination when I want to. I value the ability to have intercourse without urinating on my spouse. I value having an erection. And I value a lot of other things that I won't go into. So I think those 3 are enough.
Okay. James has said frozen.
Are you describing your situation, Jim? You're frozen on the screen, or is there any other questions?
No, we've got all the questions. This is from Eric. Can you do the seed implant treatment after a prostatectomy?
Typically, no. There are nothing in prostate cancer treatment is universal. There's 2 types of seed implants. What are called permanent or low dose rate seeds have to be put in the prostate to have a place to be put. There's another type of seed implant called high dose rate brachytherapy where they insert tubes into the area of treatment and they can put the seed on the end of a wire and radiate an area, and then the whole apparatus is removed afterwards. So there are select situations where high dose rate brachytherapy seeds can be done after a radical prostatectomy.
Bill, you want to yell it out?
Hi, Dr. Scholz.
Stand up.
Oh, hi, Dr. Scholz. Does Mac Roach do the permanent seeds, or who do you reckon? Do you know someone in California that does the permanent seeds, the old-fashioned?
Yeah, well, the PCRI hosted a very competent seed implant doctor named Dr. Steve Kurtzman up in Northern California. So you can look up his YouTube video, go to the PCRI and cross-reference it with Kurtzman, Kurtzman. You can hear him do a presentation about seed implants. He's definitely a very accomplished brachytherapist.
Dr. Scholz, can you give me some few names of doctors doing the nano knife?
Gary Onick, I think, does nano knife. But again, I have utilized this methodology very little. Gary Onick has been one of the originators. He's been around forever. I have had 1 or 2 patients treated by him in my 30-year career. They did okay.
Oh, really?
I don't have inside knowledge, but he is a reputable expert with a good reputation.
Okay. Any other names?
If people want more names, make an appointment to come see me.
Okay.
So, are there any other questions? Do you have anybody on the chat, Jeff?
No, we're all caught up in the cat.
Anybody raise your hand or put a little yellow hand if you have a question?
Or put a note in the chat saying I want to speak, something.
Well,
I have a question.
Oh, there you go.
Alan, Dr. Scholz, when can you consider a cancer cured?
Well, the usual metric is to have a low stable PSA after treatment for 5 years. That is not a perfect definition. There is a possibility of cancer coming back after 5 years, but thankfully, those rare cases usually represent very low-grade relapses that are easy to treat. So I'd say if you've had a stable, low PSA after treatment for 5 years, you can, pound your chest and say, I'm cured.
Anyone else?
I think we have nobody in the chat room.
Nobody would. Dr. Scholz, we managed to fill an hour and a half with a lot of questions, and I really appreciate you taking your this weekday night to be here and share with us. And it's a great opportunity. You should see Dr. Scholz and Dr. Moyad at the conference because they go at it back and forth. It's like dueling docs, but it's entertaining, but it's awesome. He asks you such interesting questions and you respond. I mean, you learn so much just from that portion as well.
Well, we all ride Dr. Moyad's coattails. He's such an amazing guy. He makes everyone around him look like they know what they're doing. So he's a very, very, very special entertainment level genius. And he is the moderator of the conference. He controls the tenor of the whole weekend. And he's just in and of himself. He's a real delight. So yeah, if you can come along and join us, I think you'll have a good time.
I really agree. It's extraordinary. And just to be around all these people from all over the country and sometimes all over the world. I've met people from Europe and elsewhere that come, and just to talk to them and be around other men with prostate cancer and their families is really an extraordinary opportunity, beside all the educational aspects. Plus, look, they gave us a discount as well. So it's like, just carpool with somebody. So only one you share in the parking, that'll work. How do you get info on the conference? Look up September PCRI conference, right? Google PCRI.
Well, let me bring back someone a lot more attractive than I, and she'll give you a reminder.
There you go. Thank you.
Yeah, you can go to PCRI.org, Prostate Cancer Research Institute. You can Google us. You can send a carrier pigeon. Either way, the name will work. But yeah, it's pretty simple. And then, you can go ahead and put your discount code, which is just capital S, capital G for support group. And then it'll also be all over our YouTube channel as well. And subscribe to that because a lot of the questions you guys asked tonight, Dr. Scholz has filmed extensive interviews with us on those things, like what if you're PSA negative, and he goes through all of the scans and treatments and biomarkers and immunotherapies, and he even has a video on NanoKnife and all of that. So there's a lot of content there that all you have to do is type in YouTube like PCRI and whatever keyword you can come up with in prostate. We have a video on it, and if not, please let me know because I need to make one.
Yes, you'll add a new video, right?
Exactly.
Thank you.
Thank you so much.
Thank you for coordinating all this as well, Alex.
Yeah.
I appreciate it. Thank you.
I hope you guys have a great night. See you at the conference.
Thank you.